welcome, Mohammed. It's very nice to see you and to share us this scientific activity. I would like to see you in Egypt soon, inshallah.
Inshallah. Thank you, Dr. Nabil, for the invitation. I'd like to come to Egypt again and share you also in my scientific activities and my clinical activity. Should I start?
Yes, please. I'm chairing this session with Dr. Ahmed Ghalid. We are looking forward for a very nice case from your side.
Yeah. It's about transcatheter H2H repair. And
I think you need to share your presentation.
Please?
You need to start sharing your presentation.
Okay.
Yes, now we have it.
Okay, now?
Yes.
Good, very good. So this is as an 87 years old lady. She came to us admitted with congestive heart failure. And as we see here, I think the diagnosis is very clear as a flail posterior mitral valve leaflet.
Mohammed, if I may interrupt you, we only see the echo image. Is this, do you have to start with the presentation, or you just go?
I will show the images because from the PAC system is very clear.
Okay.
The presentation it will be a little bit hazy. And I think are the images good? You see it good, huh?
Yes, we see the echo images.
Yeah. And as we see here, we have a transesophageal echo gemacht. We've done a transesophageal echo, and as we see here, it's a flail posterior mitral valve leaflet, and with a severe eccentric mitral regurgitation. So we discussed the case in our heart team, and we decided, because of the age, to do a transcatheter H2H repair. As you see here in the four-chamber view, is a very wide prolapse of the posterior leaflet, and it's for the operators who are clipping, it's very demanding and very challenging to catch these leaflets. So I showed this. This is the echo that we have done, and the patient came to us. Here also is an intercommissural view, shows us that we have a problem in the A2P2 segment. We will see it now in the 3D images, and we have very large prolapse. And with a very wide eccentric jet. So the question is always, can we clip this patient? And the answer, this patient, there's no other option to deal with except for a transcatheter procedure. So we have decided to treat her with a transcatheter H2H repair. We have two devices here. We have the mitral clip and we have the Pascal. And this patient, for this patient, we have decided to implant the Pascal system. Here also the very clear view that show us that there is a gap between both leaflets, and the posterior leaflet is prolapsing or flail. So we, for the for the patient, we have done also a 3D images, so we can exactly know where is the prolapse. And as we see here, in the posterior leaflet, there is a wide prolapse, and we have to address this issue when we are intervening with this valve. And here is very clear how severe is the mitral regurgitation. So 1 month later, we have the patient we have admitted her to make the intervention. First, the transseptal puncture is TAA guided, and there are two aspects that we have to take care about. Number one, we have to be posterior and superior to have a height from 4 centimeters. So we see here, the first trial, we have 3.1 centimeter, and this is not enough. So we have to change the position of the puncture to reach the 4 centimeter. This is important to be able to steer the catheter, which will be seen now. So this is the guiding catheter that we use to deliver the Pascal system. And here is the tip of the catheter. And in the left atrium, the Pascal system, it's extended inside the left atrium, and we have to close it when we are in the left atrium. So we can see it clearly how to prepare the device in the left atrium. And now it is ready to steer it toward the mitral valve. What do we need? We need a 3D image. So we see here the Pascal system and here the mitral valve. And we see that we don't have any contact with the wall. So we can start now to flex the catheter to engage with the mitral valve. There are two, as I said, it's a TAA guided procedure. We need the fluoro only for 2 or 3 aspects I will tell you now. But we see here the closed Pascal device, and we see the prolapse in the LVOT view and in the intercommissural view. For the orientation, we make a 3D, and the strategy was to implant 2 devices to stabilize this flay leaflet. And as we see the prolapse in the posterior part and in the P2 segment, so we have to implant the first one in the center of the mitral valve. So we can see here clearly in the 3D image. So we can see also where is the jet, and to be sure that the pathology that we attack is in this area. And here we are trying to grasp the leaflets. And as you see here, we have the anterior leaflet and the posterior leaflet on the grasp of the device. Because of the wide gap, what we are doing, we can separately grasp the leaflets. I don't have to grasp the leaflets simultaneously, because it's very difficult here. So we have decided to grasp first the anterior leaflet, and we put the clasps down, and then go to the posterior leaflet. So, and as we see here, we have the leaflets inside these clasps, but we didn't close the device. So to be sure that we are attacking the appropriate area. We have to make a lot of images to be sure that the tip of the leaflets are inside the Pascal or inside the clip. So in 3D, we are also controlling where the appropriate position is, and when we are sure, so we close the device, and this is the result after the first one. We know from the first that we have a very wide flail and a 2 Pascal or clip strategy is the best one. So first we have to see that we don't have a mitral stenosis, and to control where the Pascal or the clip now implanted. And the wrist jet, where it's coming from the lateral area. So in the medial area, we don't have a wrist jet, but in the lateral to the first device, we have a lot of wrist insufficiency. So we decide to implant the second device, but before we implant the second device, we have to check that we don't have a mitral stenosis. So we have a mean gradient from 2 millimeter mercury, so we can go on with the second one. So this is the first device. This is already implanted and it's stable. And as we see, we have reduced the mobility of the posterior leaflet. And this is one of our aims. Of course, we have to reduce the mitral regurgitation also, but first we have to stabilize these flail leaflets. And to check again where the wrist jet is, and again the gradients. So the second device is now above the leaflets, and the strategy is to implant the second one beside the first one, not to have defect between both devices, and to stabilize the flail leaflets more, so we can reduce the mitral regurgitation in this way. So we interrogate now with the second one. This is the first device, and we interrogate now with the second device. And as you see, we have here a lot of movement from the posterior leaflet, and this is the anterior leaflet, but we have a good chance to grasp both leaflets. And as you see here, this is the grasping. We have to be sure that we have enough material from the leaflets inside the clip. And then when we are sure, we try to grasp both leaflets. So we have here in position, here is the mitral regurgitation, there is mitral regurgitation, so we are in the position where we want. After closing the second one, we see here we have only a minimal mitral regurgitation in comparison to the mitral insufficiency that we had before. And we see that the leaflets are stable and good engaged inside the Pascal. The second one, the second device is fixed to the catheter, and after we control that we have enough leaflets inside this one, so we decide that to release the device. And here we control again in the 3D image, so we see that we have the two devices parallel to each other, and we don't have big defect between them. Here again, to control the position of the second before we release it. Before we release, we have to be sure that we don't have mitral stenosis. So we are measuring the mitral valve area with the planimetry. So we have here 1.7 plus 1.2, so 2.9 square centimeters. So we are happy with the implantation, and we don't have here mitral stenosis. And as we see here, we have a minimal rest mitral regurgitation without mitral stenosis, and we have stabilized the prolapse with very good result. Again, this is the final image, and before we finish the procedure, we have to be sure that we don't have a pericardial effusion, something like that. In the angiography, this is the first one, and as I said, when we implant the second one, we have to be sure that we are lateral to the first one and very close to it. So we can be sure that both devices are stable, and after controlling the result in the transesophageal echocardiography, so we are sure that we have here good results. So we release the second one, and we finish the procedure. Thank you.
Congratulations, Mohammed, for the very nice case. I just want to ask you if you have any selection criteria or preference when to use Pascal and when to use a metric clip.
Before we had the fourth generation mitral clip, where we could grasp the leaflets separately. Before that, I have preferred Pascal because I can grasp the leaflet separately. If I have a prolapse or a flail leaflet or something like this. But the patients for the Pascal and the patients for the mitral clip are the same. I can do this and I can do this, but I prefer when it's difficult to grasp both leaflets simultaneously to take Pascal. Now I have the fourth generation also of the mitral clip, so I can do it also with the mitral clip. And if I have a smaller mitral valve annulus, the mitral valve area, and normally we have minimum 4 centimeters square, but if I have 3.5, 3.8, so I choose Pascal because the grasping force of the Pascal is not so strong like the clip. So the possibility to have mitral stenosis after clip is higher if I implant it in these patients with a smaller mitral valve area.
Okay.
طيب السلام عليكم محمد شريف. This is أسامة رفاعي. Very nice to see you Sharif in Berlin. Doing good job. هنيئك. Congratulations. Sharif is the son of Ain Shams University and we are proud of him. Let me ask a few technical questions. I mean, this is an unusual presentation, 87 years old, to present with a severe mitral prolapse and mitral regurgitation. I mean, this happened at rupture chordae, for example, or what is your opinion?
She doesn't have coronary artery disease. I think it's degenerative. We have seen a flail, a posterior leaflet. That's one of the chordaes. I think it's ruptured, but she was not in cardiogenic shock. Coronary artery disease also is not a problem. I think this is some degeneration or something like this.
So, thank you. Just any data about, I mean, how much leaflet separation is contraindicated for you to abandon this technique?
We say 10 millimeter, but we have done also 12 and 13 millimeter. Because we can grasp one leaflet after the other. So I can, if I have a wide gap, I can grasp the anterior, this is always the anterior leaflet, and then I pull the clip or the Pascal a little bit and I go to posterior so I can grasp the other one. So 10 millimeter is the maximum, but we can tell 12 millimeter gap we can clip.
This is my technical last question, yes, because I never knew that in the old generation about mitral clip you can close and open and close and open. I mean, it's only once you close and that's all. So it seems that some...
the fourth generation now. This is the fourth generation, so we can make it separately.
You can grasp and then pull it and grasp the other one. It's quite interesting.
Yes.
Thank you, thank you.
So one last question, if I may. Do you think that after having TMVR, there will be still room for a mitral clip, or it's going to be a historical procedure?
There are now two valves that are having studies. This is the cardio valve and the evoke valve. Sorry, the M valve from Edwards. And the tendine, but it's the tendine is transapical. The problem is the transcatheter valves are not well developed. We don't have a lot of data. But if we have them, you cannot treat all the patients because we have sizes. So we have also a limited capacity to treat every patient with the new valves. So I think the mitral clip or the Pascal, we will still need them, like the surgeons. The surgeons, they repair and they replace. So I think that we will have both. And the inclusion criteria for the valves for the patients, the eligibility criteria to implant the valves are very strict. So I don't think that we will need. I think we will need the transcatheter atrial repair also after we have valves in the mitral position.
Thanks, Mohammed. It was nice having you with us, and looking forward for future scientific meetings, inshallah. Okay.
Inshallah. Thank you.
So next is a live in a box, again mitral clip case with acute mitral regurgitation. It's quite interesting, acute mitral regurgitation. I'm sorry, I brought the wrong one. I'm sorry. It's a very challenging case by Raquel del Valle, Oviedo, Spain. Dr. Raquel. you don't hear.
I think you're muted.
Good afternoon. Can you hear me now?
Yes, very clear.
Yes, we can.
Okay, perfect. So first of all, I want to say thank you to the organization for the opportunity to be here with you today in such an interesting meeting. And I'm going to try to share my computer with you. So I think you can now see my slides. Is that correct? Do you see them properly? Perfect. So I'm going to present a case of a bicuspid aortic valve that you know is one of the hot points now in TAVI. This is a case we performed like 10 days ago, and the patient is already at home and doing great. He's an 83 years old male diagnosed with a pectus excavatum, diagnosed also with persistent atrial fibrillation and on chronic anticoagulation, and he underwent atrioventricular node ablation and permanent pacemaker implantation some months ago. He was known for having a bicuspid aortic valve, but he was admitted this August in a clear heart failure, and we saw that the ejection fraction had gone down. He had an ejection fraction of 40%, and a low flow, low gradient aortic stenosis with a mean gradient of about 32. His calcium score was over 7,000 Agathon units. He also was diagnosed with a renal failure with a filtration rate of 37, hemoglobin 14.4, and the EKG showed no anomalies because he was in a pace moving. No significant coronary artery disease, as you can see here. We presented him in the heart team, and we decided to go for TAVI. The most important thing in these patients, I think, is to be carefully with the anatomic analysis. So we perform a CT scan in every patient, and it's of utmost importance for the bicuspid valves. Here you can see the anatomy of the patients. It's a bicuspid with fusion of the right and the left sinuses, as you can see here with a raphe. The anatomy of the aorta is that of 3 sinuses of Valsalva. So we can check here, and that is a type 1 of the Siebert's classification. We can identify 3 sinuses of Valsalva and 1 raphe. This is the most frequent bicuspid we can usually find. So now we have the problems that we don't know what to measure when we are talking about bicuspid. For tricuspid valves, we always measure the annulus, but we have demonstrated here that the fixation of the prosthesis in case of bicuspid valve is not at the annulus level, but mostly at the supraannular level. That is the point where it is more underexpanded or more constricted. So several groups have postulated that for choosing the TAVI, the prosthesis to implant, we have to take into account not only the annulus measurements, but also the supraannular measurements. There are several different series. We don't know exactly what to measure. Somebody has postulated to measure the intercommissural distance approximately 4 millimeters above the annulus. Others have postulated to go to the Lyra plane, that's the leaflet insertion at the raphe. It's about 8 to 10 millimeters above the annulus. Some of the people have proposed a more complex algorithm that's called the Casper that we are going to analyze further. So the question is, where should we measure to choose our size? These are those measurements for this patient, and this patient made it quite easy for us because all the measurements were quite consistent. We can see the aortic annulus here. The perimeter is 86.5, that's a diameter of 27.5. If we go up to the intercommissural distance, this measures 4 millimeters above the annulus, it goes bigger, it goes up to 31 millimeters. And if we go up to the Lyra plane, we check that the diameter is 81.6. This is wrong here by 1 hour. It's 81.6. We went also to the Casper algorithm. The algorithm is a little bit more complex. It takes into consideration the annulus diameter, that's the reference, and then it is modified according to 3 factors. First of all, the length of the raphe. Second, the volume of the calcium in the aortic valve. And third, we have to check whether that calcium is more prominent at the raphe or on the opposite part. For this patient, the raphe was 13.1 millimeter, the calcium was over 600, and the calcium was not prominent at the raphe side. This, once we apply the algorithm, modulates our measure, and it goes down from 27.5 to 26.5, this number to be the reference number for choosing the valve side. We decided to go with a self-expanding valve, with the Evolut valve, and we can check all our measurements here in this table. So our annulus diameter is in the range of the 24 prostheses when we go by the annulus. It's in this same range when we go for the intercommissural level. It's just between the 29 and the 34 because the measure was 81.6. If we check the LIDAR plane, and it's also in this area, in the 34, if we go to the for the Casper. So in this case, it was quite easy because all measurements were quite consistently with the 24 Evolut. It's not so easy in other patients. Those are the other anatomical factors. The sinuses of Valsalva are good size, high coronary arteries takeoff. We can see the calcium here. It's more prominent in the non-coronary cusp, and we can clearly see the raphe here. And those are the working projection. It is important to know the type of bicuspid also because these bicuspids are easier than the typical type 0. Because here we can identify the 3 sinuses of Valsalva, so it's much easier to identify a working projection. If you only have 2 sinuses, you can not get the alienation of the 3 sinuses, of course, because one of them does not exist. So those are the projections we are going to work. That's the traditional one, and that's the sinus overlap. And this is the projection we are using for the last 2 years, approximately. These are the abscesses, the vessel. You can see these are very good size, but with circular calcium here. And we also decided to use a cerebral protection device here because it's a bicuspid, and it has been described that the rate of embolic events is higher. So these are the measurements we need for the sentinel impact. This is also very interesting. This is something new. I'm sure you have seen it in other presentations, in other courses. This is the FIOS. It is the finite element analysis. This takes the CT scan of the patient, and it calculates the interaction the prosthesis is going to have on the tissues of this patient. This is important because it gives us information about, as you can see here, the frame deformation, that's the frame going to suffer, the contact pressure that the prosthesis is going to apply on the different parts of the aorta, and it also gives information about the estimated regurgitant fraction of the patient. When you send a CT scan for a field reconstruction, you always get information of 2 valves of different sizes. In this case, I asked for the 24 and the 29 valves, and you can see the prosthesis in a higher position or in a medium position. And you can compare all these to choose which valve and which position you want to look for. So finally, we decided we went for an Evolut Pro because all measurements were in the Evolut Pro. And what is interesting here is that it's estimated that the regurgitation is going to be less than moderate. We have to check, or we have to confirm if this is capable of predicting the result. So our final plan was to go through a right femoral axis. We are going to use the right radial for cerebral protection device, the Sentinel in this case. We are going to use a double-proof Landerquist guide wire. We are using this guide wire in difficult cases, like in bicuspid or in 34 valves that are bigger, and it's not so easy to implant. We decided to go with a balloon valvuloplasty, with a small balloon, just a 23 balloon, because as you will remember, the calcium score was over 7,000, so it was a very calcified valve, not that we do it routinely, just in this case. And it will Pro Plus 34, working on the sinus overlap projection that we have been doing for the last 2 years. We don't, the patient already has a pacemaker, so we are, but we are going to do our fast pacing over the guide wire because it's faster to do the on-off of the pacemaker. And we prepare the femoral closure with a MANTA device. Here you can see the puncture, and you can see clearly the calcium on both sides of the leg. And we are taking the measure here for the MANTA device. You can see the guide wire. We are measuring the distance here. I'm not sure if you know the device. Once you get to the lumen, you get blood here. And there are some numbers in the device. Now, we have blood here. We check when it disappears. You are retrieving the device. And when it stops bleeding, here, you can check the number here, and that's the number you have to remember for closing the femoral afterwards. So we cross the valve, and these are the results we got. We got a peak-to-peak gradient of 36. Remember that the ejection fraction was 40%, so it's under 40, but that was expected due to the moderate left ventricular dysfunction. And what we did afterwards was to implant the Sentinel device. We went through the right radial, and we can see here that we are implanting the first device on the brachiocephalic trunk. Then you flex the device. You can see the guide wire here going into the left carotid. Now we are approximating the device to the left carotid. And now we will push the system. So we have the second filter implanted. We have the brachiocephalic trunk here and the left carotid filter there. We check again the working projections. Despite we always reconstruct the angiocity, we always check the projections during the procedure. That was the classical projection with the 3 sinuses of Valsalva. And this is the projection with the overlap of the right and the left sinus. And now that we have everything prepared, we check the prosthesis. This is a Pro Plus, so we have to check that both these dots are here, and also that this line does not go farther than the 4th node. And as we have scheduled before, we perform balloon valvuloplasty with a balloon of 23 millimeters. It expanded properly, although it's a small balloon for this anatomy, and we started the implant. What we are doing now is trying to work high. We usually start the deployment with the marker at the mid-peak tail. In this patient, that's not so important because he already has a permanent pacemaker, but that's what we are doing. Now we are starting to liberate. That's very a curious thing here that you can see the prosthesis is to the right, when you usually see it to the left, to the outer car, but now it's to the right. And you can see here that the prosthesis is just at the annulus layer, even a little bit higher. You can see there's some calcium below the prosthesis, but we decided to try to go there, and because we can retrieve in case we don't like it. We continue with the implant. And as you see here, this does not look very good. We did not finish the implant because the prosthesis had a weird form, and also this was above the anus. This is the projection, and we can see here, this is the left anterior oblique. We always check once we have the prosthesis placed in the sinus overlap. We always go to the left anterior oblique to check also for the left sinus, but you can see in the aortogram that this is above the aortic annulus. So we decided to retrieve the valve. Also, it's a very weird form, so we performed another valvuloplasty with a bigger balloon to allow it to open properly in the next deployment. Here's the other valvuloplasty, the second valvuloplasty. We started a little bit lower this time because, as I told you, he already had a pacemaker, so we didn't have to force. We are still opening it. Still, it's a little bit underexpanded here. And when we go to the left anterior oblique projection, it looks good. It's interesting, the difference. On the left, you can see the left anterior oblique where the prosthesis looks great. On the right, you can see the sinus overlap projection with when the prosthesis looks really underexpanded. And that's something that we have seen frequently, that it looks worse on the right projection. But the position, the depth, we thought it was correct, so we decided to open the valve and post-dilate later if needed. So we open the valve, look how bad it looks here. This is the traveling, where we can see the different morphology of the valve clearly from one projection to the other. We perform the valvuloplasty here. And on the next projection, you can see that it now looks better. Not perfect, but it looks much better. It is more expanded. This is the control after the valvuloplasty. You can see the disappearance of the gradient, a very good diastolic gradient that suggests that there is not significant aortic regurgitation. And you can see the control with just mild, play it again, just mild aortic regurgitation. We closure the device with the Manta device, and the angio, so not complications at this level. And that's the case I'm going to leave this. That's the case I wanted to share with you today. Of course, any question is welcome.
Okay, thank you, Dr. Raquel. This is an interesting presentation and elaborate. I'm just wondering about, I see that you do prefer pre-dilatation. Would you do this routinely? And I have some concern about the bicuspid aortic valve. If you dilate it, it may end up by severe aortic regurgitation. You'll be in a mess.
Yes, we don't do it routinely. Nearly never we do pre-dilatation. We just pre-dilate routinely in cases of severe ejection fraction depression, but not routinely. In this case, or in cases of severe calcium. In this case, we just did it because the calcium score was over 7,000, and it was too high, and we felt that it will facilitate the position of the valve. But we don't usually do pre-dilatation.
Thank you. Have any more questions in the audience?
Thanks a lot for the. You have been after the Bavard new registry. I think we are much more comfortable with the sizing for the bicuspid aortic valve. Do you still go for pre-dilatation for the sake of balloon sizing for bicuspid aortic valve, or you don't do this anymore?
No, since we have the scanner, the tag, we don't do balloon sizing. No, for bicuspid, we left it a long time ago. We always use the scanner, because with balloon valvuloplasty, in a bicuspid, you always have the problem to even if you go with a small balloon, you always have the risk of getting some regurgitation, so we don't do that.
Okay, great. thanks a lot for the interesting topic, and looking forward for having you with us in future meetings. Okay.
Thank you.
It would be great. Thank you very much, all of you. Enjoy. Thank you.
Okay. So the last case study, multiple challenges. He is presenting the Prince of TAVI in Egypt. Actually, Ahmed Sayyid, he worked in Germany, learned there, came back to Egypt, started the TAVI program. Very hard track, but eventually succeeded. Now we have some registry, some work, some research and training for others. This technique is now is really surviving and extending even to the low risk, as we all know. So Ahmed and Shams University.
Thanks, Dr. Sam, for the presentation. Actually, it was Dia was planning to do this presentation on behalf of Ain Shams TAVI team, but he was busy bringing us a younger TAVI operator. Actually, he's one day Ibrahim Dia Kemal. So I'm presenting on his behalf. This actually was a very tough, challenging case that we did a couple of months ago. He was a 71 years old male patient who was diabetic, hypertensive, known as, with ischemic heart disease, impaired ejection fraction of 35%. He presented with acute pulmonary edema. He has a high STS score and a high UR score. This is his echo data, as you see, a very tight aortic stenosis, severe pulmonary hypertension with a mean gradient across the aortic valve of 53, despite the impaired ejection fraction of 35%. His CT showed a bicuspid aortic valve morphology. The patient was shocked and he was totally dependent on positive inotropes. Adding more challenge to the case, he had a horizontal anatomy with estimated or calculated angle between the aorta and the LVOT of almost 60 degrees. And adding more challenge, he's having a bicuspid with fusion between the right coronary cusp and the non-coronary cusp. The commonest type of bicuspid aortic valve is having a fusion between the left and the right coronary cusp. In this case, he had a fusion between the left and the non-coronary cusp, and we'll see how this fusion at this point made our procedure even tougher. His calculated parameter was 83, which made us go for the Evolut R size 34, and he had adequate spacious enough sinuses of Valsalva. Adding more challenge, he has a low-seated left main with calculated height of the left main of 8.8. This is a bit low-seated left main. And you can see the calcium chunk, a large calcium chunk on the left coronary cusp. His access was okay. I think this is the only thing that was not challenging in this case. So, accidentally discovered a liver mass. So before proceeding with the procedure, we had to consult our oncologist to evaluate the life expectancy of this patient, and he told us this patient is having an expected life expectancy of more than 1 year, so we can proceed with our procedure, and then he can proceed with further oncological treatment. Our plan was to go for a transfemoral TAVI with an Evolut R34 from the left femoral axis using a surgical cut down under general anesthesia. And because of having such a critical patient who was on positive inotropes, we had to have a cardiopulmonary bypass machine on site. We even cannulated the right femoral artery and vein, so if the patient crashed at any time during the procedure, we will immediately connect him to the cardiopulmonary bypass. We don't have to wait for a few minutes resuscitating the patient. We can immediately go on the heart-lung machine to offer him the best care. And we'll go from the left radial axis to go for left main protection. And we did him PCI to the LED and the LCX, and one day before the procedure. You can see here, this is Judkin left 4 guiding catheter cannulating the left main, 2 wires already present in the LED and the LCX. A transient pacemaker is inserted from the jugular axis, and this is the right femoral artery cannula, which is ready to connect him on the heart-lung machine in case he crashed. We already crossed the aortic valve with the help of the Judkin right catheter. The Amplitz left catheter didn't help. So this is a Judkin right catheter, which is inserted from the left femoral axis. So we now have an access to the left ventricle that was exchanged with the pigtail that's already now placed in the apex of the left ventricle. And here you can see a stent is already inserted in the LED to, just in case there has been any encroachment on the ostium of the left main, we can withdraw the stent and deploy it at the ostium of the left main after valve deployment, what we call the snorkel or the chimney technique. So now we have a stiff wire already inserted in the left ventricle from the left femoral axis, and then this is the valve check step. Now we decided to go for pre-dilatation because of the heavily calcified valve and the unfavorable anatomy and the horizontal axis. So we were planning to go for pre-dilatation with this balloon, and then it gets more challenging. We can't cross the valve. Most probably because of the fusion between the right and the non-chronic cusp. The valve doesn't take the curve, it's not able to push the valve inside the left ventricle. So we need to go for a body wire. We need to put another stiff wire inside the left ventricle to facilitate introduction of the valve inside the left ventricle. So we need one more axis. Actually, the left radial axis is used with a Judkin left catheter cannulating the left main. The right radial axis is not possible to use because of it was thrombosed actually, and we had 2 femoral axes, one for the valve and one for the pigtail. And the right femoral axis was used with a femoral artery cannula. So our surgeon just could make a modification of the right femoral artery cannula, and we could insert a sheath inside this cannula, so we could put the pigtail from that side, and we used the other axis to insert a body wire. So now we had to recross the aortic valve. You see, this is again the Judkin right catheter, and this is a hydrophilic straight-ended wire. One stiff wire is already inserted, and now we are crossing with another stiff wire. So now we have 2 stiff wires inside the ventricle, and again the valve doesn't cross. What's next? We had to go for, we needed more support, so we went for what we call the body balloon. So we, it gets more and more challenging. So now you can see, this is a balloon already inserted across the aortic valve. And we tried to push the valve inside the ventricle, and finally we could do it. You can see there's acute severe aortic regurgitation, and as you can expect, we started to open the valve. Expected for cardiac arrest for 1 minute, and the patient was back. The the first deployment was a bit deep, so we had to retrieve the valve and implant it at a higher position. I think you can appreciate the calcium chunk on the left coin clasp that might have encroached on the ostium of the left main. This is why we went for left main protection at the very beginning. At that time, the valve was too high, so we went deeper for implanting the valve, and that was the final position. The valve was deeper than we wanted, actually. It was around 6 to 7 millimeters deep in the ventricle. But with the challenging anatomy and the very horizontal aorta, this is an accepted result. The paravalvular leak was mild, and the patient actually, his hemodynamics improved immediately after therapy, and here was, we were able to wean the apostolic troops immediately after the procedure, and the patient was discharged 1 week after that procedure. So therapy is a feasible option for shocked critically ill patients. Hearting and adequate pre-procedural planning is your key to success. When you have such a challenge with an uncrossable valve, using other valve platforms like the Sapien 3 with steerable delivery catheter, using a body wire, a body balloon techniques, using even stiff wires, but actually we're using the lunge request, which is the stiffest wire available. Having a prepared ECMO or a cardiopulmonary bypass machine should back you up whenever you have similar scenario. Thank you.
Thank you, Ahmed. It's a very interesting case, challenging. Amazing. And I like the way you presented it. This is an international presented case. I mean, you should present it in an international conference. It's really challenging and giving lessons. Now, one trick, maybe if you use a bigger balloon to split this closed commission in the posterior one that was hindering the valve from going in. Have you thought about?
The problem is with the problem we faced was actually the angle between the aorta and the LVOT, and I don't think pre-dilatation with a larger balloon would have helped. Yet we might have developed a severe aortic regurgitation that might have made the situation worse. But
amazing. It's really life-saving, as you say. Can you explain the balloon, the body balloon technique in the aorta?
Okay. So it's always first you go for the body balloon, the body wire. If it had, okay. If it didn't, you need more support, so you can just put a balloon, deflated balloon, over the body wire. So one axis is having a stiff wire with the valve on top, and the other stiff wire is having a deflated balloon on top. It can just both wires are in the left ventricle. Yes. The third step that we didn't do here, we didn't need it actually, if the valve didn't cross. So what you can do is you inflate the balloon and then push the valve while deflating the balloon. This might help advancing the valve inside the left ventricle.
This you're creating some Venturi effect. When you deflate something, some Venturi effect to push it down to the left, and it's a smart idea.
Do you think if all that failing, you can use another type of valve?
Yes, definitely. I think in this particular case, having other valve platform like the Sapien 3 with a deflectable catheter would have made things much easier. Yes, definitely, yes.
So the final question is the protection of the left main. So what is the moment can you retrieve back or remove the guiding catheter through the wires? You know, maybe trapped by the valve itself. It's a certain moment that you can.
This is a very important question. We always use a guideline catheter and we had a galvanic catheter in this case. So you park the wire, the PCA wire, and the stent, and the guide liner inside the LAE, and you take your guiding catheter at a high position in the aorta. So after valve deployment, you check for the coronary filling. If you think that the left main is encroached upon, so you can withdraw the stent, and we are never afraid of jailing of the guideline catheter. So if you didn't want to deploy the stent, you simply take your wire and the stent inside the guideliner and take the whole system out. So there is no risk of stent embolization.
Any question from the floor?
I think this is an amazing presentation with a challenging case, and we end this session and probably the whole conference with leaving you with enthusiasm to complete this therapy program and teach more people. Thank you very much. Assalamu alaikum.
طبعا I would like to thank you all. I would like to thank you, the organizing company. I would like to thank Dr. Ashraf Badawi very much for his great organization and arrangement. Everything went very smooth. Actually, I didn't feel any difficulty during the 2 days, the live transmission, the lectures, the presentations, all of this. I would like to thank very much Dr. Ahmed Said, Dr. Dia, for the great program and great lectures they choose, actually. I would like to thank Dr. Ahmed, Dr. Osama, actually, for being with us on Friday, Dr. Ahmed, Thursday, Friday. I would like to thank very much Dr. Cesar Moise and his team. Actually, it's always give us very good presentation and live cases, and share with us in most of the scientific activities we are doing. At the end, I would like to thank the department, my preferred department, the cardiology department, Ain Shams, and all my friends for being with us, supporting this elegant scientific meeting. We are planning to have such meeting every year, sponsored by Sanofi, and never forget to thank Sanofi team for their support and sponsoring this scientific activities, today's activity in this luxurious hotel, actually. I will leave the floor to Dr. Ahmed Said just to wrap up the 2 days scientific presentations. Dr. Ahmed.
And we thank you very much, Professor Nabil Barak. It's such an eminent meeting. Ahmed,
thank you.
Thanks, Dr. Nabil, for giving us the opportunity to coordinate this interesting scientific meeting, and we're looking forward to have you with us in future meetings, inshallah, in the future years. It's planned to be an annual meeting with covering all the interesting intervention, up-to-date techniques from Ain Shams University and our Spanish friends from Oviedo University. Thanks to all the international speakers that have made that scientific meeting very fruitful and valuable. I have to mention Marwan Saad, our colleague in the States, Hisham Abdelaziz in the UK, Shihab al-Itribi, Wael Kilani, Wael al-Mallah, Tariq Rashid, Muhammad Saber, and of course the Spanish amazing team, Pablo Avanzas, Raquel Del Val, and Isaac Pascual. we hope that in these 2 days we have covered most of the interesting topics, and as we mentioned, looking forward for more and more interaction and success in the future years. Thanks for all the attendees and for those who have been following us virtually. And we hope that next year event that the COVID era would have been passed, and that we are back for the physical meetings that we have been longing for. Thanks, Ashraf, and the very professional IRIS team, and I think that's it. Okay, thank you.